Hello, dears, and welcome to Al-Hussaini Virtual Lab, Pathology Talks, Tips, and Practical Tips. What I'm going to be sharing with you today is a nice example of a rare tumor that can have potential pitfall. This is a case of uterine adenosarcoma. So this is a case of a 51-year-old female patient who was discovered to have cervical polypoidal mass. So the cervical polypoidal mass was excised. And as you can see here from the low power magnification, the first thing that would come to mind once you see it on low power is this. It looks like phyllodes tumor of the breast, and this is exactly the tip or the clue that should alert the diagnosis and the differential diagnosis, because adenosarcomas on low power magnification typically have this phyllodes like appearance. So we have the glands sometimes with this serpentine growth pattern, and then we have condensation of the stroma around the gland with somehow predominance of the stroma over the glandular component. This is another focus, and again, this really reminds everybody that sees it on the low power magnification of phyllodes tumor of the breast. So we have the glandular component, and then we have the stromal component cuffing closely aligned to the opposing the epithelium with some perpendicular growth around the epithelium. This is the typical appearance of adenosarcoma. Now, on higher power magnification, as you can see, the stromal component is actually, as the name implies, it's the sarcomatous, it's the malignant component where we have proliferation of spindle-shaped cells, sometimes with scattered mitotic activity, and the cells usually have this perpendicular alignment of the nuclei against the lumina of the glandular component. So this is another focus where we have actually several mitotic figures seen here within the stromal sarcomatous proliferation, low-grade sarcomatous proliferation, not much in the way of atypia, not much in the way of sarcomatous overgrowth, meaning that there is no area where the high power magnification is composed solely of sarcomatous growth. Another focus where we have the benign epithelium, and then we have the condensation, the cuffing of the glands by the malignant spindle-shaped cells with mitotic activity. And remember that the alignment of the nuclei sometimes in the form of with the perpendicular alignment of the long axis of the nucleus against the basement membrane or the luminal aspect of the gland helps to support the diagnosis. And definitely this stroma is much more condensed and cellular than the usual stroma of the breast. Now, this is another focus, but here we start to pay attention to the glandular component. And as you can see here with the glandular component, it's completely benign. There are no features of malignancy. There is some perhaps proliferation of ciliated epithelium like ciliated metaplasia. And there is another focus that even it's more clear where we have the cilia and we have the intercalated cells. So this is like a tubal metaplasia. Mind you, here the stroma is exactly the same stroma that I shared with you in the slides before. And here is another focus where we have the glandular epithelium, now this time showing the squamous metaplasia, but still the stromal epithelium showing the exact same appearance. And another focus where we have perhaps here some ciliated epithelial metaplasia, and here we have mucinous metaplasia. And again, both sides are seen within the confines of the glandular epithelium, the benign proliferation. Now, because the polypoidal mass was really big, protruding through the cervix, we expect that the tip of the polypoidal mass will show some necrotic changes with fibrin and congested blood vessels. But what was really worrying that the glandular epithelium near this infarcted or necrotic tip was really very pleomorphic. And this is exactly what is called the hobnail type of metaplasia that we encounter, and this is a typical potential pitfall for calling this higher grade something like serous carcinoma, for example, of the epithelium. Now, moving into the immunostain, P16, because the mass was potentially or originally described as cervical polypoidal mass, I alluded to do P16 just to make sure that there is no evidence of a block positivity in the epithelium, meaning ruling out HPV-associated endocervical adenocarcinoma, and in other areas it was completely negative. It does not have any significance of positivity in the stroma. Now, NAPSN-A, I did it just on the areas where we have the atypical epithelium, because we've described recently in a recent paper NAPSN-A positivity in hobnail metaplasia that is seen especially in polypoidal lesion, a potential pitfall that we have to pay attention to. So NAPSN-A was completely negative, but even if it was positive, this goes with hobnail metaplasia, does not mean that we're talking about a clear cell carcinoma. Now, CD10 was positive in the stromal cells, and ER was positive both in the glandular component and some focal positivity in the epithelium, and the P53 showed this mosaic growth pattern or staining pattern in the epithelium, supporting its benign nature. I have to say that the case can easily be diagnosed without the need to do immunohistochemistry. Immunohistochemistry does not really add much to the support of the diagnosis. It's a morphologic diagnosis rather than an immunohistochemical dependent diagnosis. So the final diagnosis that was rendered on the polypoidal mass from the cervix, adenosarcoma. The patient underwent hysterectomy, and actually the origin of the tumor was found to be from the corpus, uterine corpus, rather than from the cervix. This is a very typical scenario of this rare tumor, and even in imaging, they cannot always be sure of the origin of the tumor. So remember that adenosarcoma, whether this is presented in the form of a cervical mass or a uterine mass, usually presents as cervical polypoidal lesion, and on the low power magnification, we have to pay attention to the typical appearance, which is, as in this case, reminiscent of phyllodes tumor of the breast. There is a benign glandular proliferation surrounded by, cuffed by spindle cell sarcomatous proliferation that is usually of low grade and not of high grade. Scattered mitotic figures can help to support the diagnosis. Immunohistochemistry is not of major importance in rendering the diagnosis. A variety of epithelial metaplasia can be encountered. This should not sway the pathologist away from rendering the appropriate diagnosis for the case. The treatment usually is hysterectomy, and then the stage depends on the extent of invasion of the tumor into the uterine wall. I hope you find this tip useful in your daily practice. Thank you.